Let's begin with part 2 of cardiovascular system. So here I'm going to discuss about the pressure volume loops in a simple way. So the first point is to observe this black line, and the first point here represents the isovolumetric contraction. So isovolumetric contraction is a period between the mitral valve closing and the aortic valve opening. So it is a time where mitral valve is closing and aortic valve is opening. It is ready for the systole. So that is the time is called as isovolumetric contraction. It is a period of highest oxygen consumption because it is going to ready for the ejection of blood outward towards the aorta. So the second step is systolic ejection. So it is a ejection that period between the aortic valve opening and closing. So the aortic valve is opening here so that the blood is ejecting out into the systemic circulation. So the next third point here represents isovolumetric relaxation. That is a period between aortic valve closing and now the mitral valve will be opening because the blood from the left atrium should be coming to the left ventricle. So the mitral valve is opening here. So you can remember it like the first one is mitral valve closes here in the first point because it is isovolumetric contraction. So mitral valve closes and the left ventricle is contracting, getting ready to eject the blood out. So here in the second step the aortic valve opens and the blood is ejected out, and in the third step what happens is there is isovolumetric relaxation. So the third step is isovolumetric relaxation where the aortic valve is closing and the mitral valve is opening. So you can see here the mitral valve opens so that the blood from the left atrium will be coming to left ventricle. So the fourth is nothing but rapid filling just after mitral valve opening. And fifth one is reduced filling, that is just before the mitral valve is closing. So as the mitral valve is closing, again some of the blood coming from the left atrium will be decreasing, and again the mitral valve you can see here it closes here, and in the first step again what happens is aortic valve is ready to get open. So this cycle continues like this, and this is what we need to understand. This is a cardiac cycle. So here we will see some terms in this diagram, like you can see end systolic volume, end diastolic volume here. End diastolic volume is nothing but equal to the preload, right? So you can see the green color here represents the preload where there is increase in stroke volume. So the preload also as the preload increases, stroke volume increases, right? And next this blue color represents afterload. If the afterload increase, aortic pressure increases and the stroke volume decreases because afterload is like an opposing force for the left ventricle to pump against it. You know that afterload is nothing but mean arterial pressure. So if mean arterial pressure is high, it is hard for the left ventricle to pump against. So the aortic pressure will increase, stroke volume will decrease, and the end systolic volume will increase. So in this diagram you can see this blue color has come so much far away from the end systolic volume, so that represents the end systolic volume has increased. And you can see this blue color is representing afterload, that is increase end systolic volume and normal end diastolic volume, whereas there is increase in aortic pressure. So next, this orange color represents the contractility. If there is more contractility, there will be more stroke volume. If there is more stroke volume, there will be more ejection fracture. If more ejection fracture means there is a decrease in systolic volume. You can see this orange color is coming away from the end systolic volume, so this side it is decreased. So if something is moving in the graph towards the left side of end systolic volume, it is decreasing. If something is moving in the graph's right side to the end systolic volume, that is increasing. So that thing we need to remember in the case of this pressure volume loops. So here on the axis you can see on the x-axis you can see left ventricle volume, and you can see here the left ventricular pressure. So like this we made the graph. Now we are going to discuss about this graph. So this is also very easy. First we need to discuss about the heart sounds. So the first heart sound is S1. It is produced when the mitral and tricuspid valves are closed, and it is loudest in the mitral area. Next, coming to S2 sound. Here you can see S1 is where mitral and tricuspid valve close. So according to this graph, if you see here the mitral valve closes, right? So here the S1 sound is heard. Next, coming to the S2 sound. S2 sound is heard when aortic and pulmonary vein both are closed. So it is loudest at left upper sternal bladder. Next, coming to S3. S3 is seen in early diastole, that is during rapid ventricular filling. So when the ventricle is filling, S3 can be heard. and it is best heard with the patient in left lateral decubitus position, that is patient turning towards the left side. It is associated with increased filling pressure, like in the case of mitral regurgitation there will be more increasing pressure in the left atrium, right, and in aortic regurgitation, heart failure, thyrotoxicosis. So all these conditions you can have increased filling pressure, and more common in dilated ventricles because there is more filling pressure, so the ventricle gets dilated. And it is normal in childhood. You can see here it is normal in children, young adults, athletes, and also in pregnancy. S3 sound is heard in the heart, which is not a problem. But if you see S3 sound other than this situations, then it is a abnormality because there is a rapid ventricular filling in that case. So that in S3 you can also see whenever there is more left atrial pressure, then you'll get S3 sound. So turbulence is caused by blood from left atrium mixing with increased end systolic volume. So why the sound is coming is because end systolic volume, some of the blood will be remain in the left ventricle, and again the left atrium blood is coming more. So these both are mixing, it is causing a S3 sound. Now coming to S4 sound, you can see here S4 sound is seen in late diastole, that is also called as atrial kick. It is caused by blood entering the stiffened left ventricle, that is the hypertrophied left ventricle. So you can understand if the blood is passing through the hypertrophic left ventricle, the sound, the turbulence is created, and that is a S4, and it is best heard at apex when again the patient is in left lateral decubitus position. Here there is a high atrial pressure, and it is associated with ventricular non-compliance or hypertrophy. This can be seen in normal adults because in adults there will be having more hypertension. Because of more hypertension there will be more afterload, so the ventricle compensated by undergoing hypertrophy. So it is common in older adults, but it is abnormal if palpable in younger people. So S4 is abnormal. Any of these heart sounds are abnormal if we heard in some different cases. Otherwise, as we discussed in like S3 is common in pregnancy, athletes, like that. In that cases it's normal. So you can see here S3 and S4 are low pitched heart beats which are best with the bell. You can hear them with the bell of the stethoscope. Now let us discuss about the jugular venous pulse. So that is also called JVP. Actually this JVP graph represents a right atrial pressure curve, okay, only about the right atrium we are understanding. So there are some mnemonics like if this A wave represents A for atrial contraction, okay, like that you can remember, and C wave represents right ventricle contraction. So this is atrial contraction, right atrium contraction. This is right ventricular contraction. That is when the C is also for closure, when the tricuspid valve is closed and the right ventricle is contracting. So first the right atrium contracts, next the right ventricle contracts with the closure of tricuspid valve, and X represents the descent. You can see this is the descent downward. Relaxation, atrial relaxation. So right atrium contraction, right ventricle contraction by closure of tricuspid valve, and again this is a right ventricular relaxation. X, you can see X in the relaxation word, and X descent, okay. And next coming to the V, that is increase in volume against tricuspid valve, that is right atrial pressure is increased now. As the tricuspid valve is closed, the right atrial pressure is increased. V for increase in volume against tricuspid valve in right atrium. And Y represents the emptying into right ventricle. So now as the right atrial pressure is increased, again it will empty into the right ventricle. So that is Y descent. So this Y descent is prominent in constrictive pericarditis. Why you can understand? Because there is more constriction, so the more blood will be squeezing into the right ventricle from the right atrium. It is absent in cardiac tamponade. So that is an important point you can see here. The emptying is into our right ventricle. It is prominent in constrictive pericarditis, but it is absent in cardiac tamponade. So once again let us revise this JVP. Very easy if you remember. A for first A, you can see here. This first A is for right atrial contraction, next C is for right ventricle contraction when tricuspid valve is closed. Next is X is for right ventricular relaxation. So first right atrium, next ventricle but a contraction, relaxation. Next the right atrium is getting more volume into it. So as it has got more volume, again it is releasing the blood into the right ventricle from the right atrium to right ventricle. That is Y is for emptying from right atrium to right ventricle. So this is about JVP curve. Now we'll go and understand this. Let us try to guess the pressure volume loops without the headings. Okay. So you can see the first one here. In this curve, if you see, this is the end systolic volume here. and this is the end diastolic volume. As we discussed already in the cardiac cycle, if something is moving towards the right side of end systolic volume, it indicates that it is increased. So it indicates that there's increase in end systolic volume. So increase in end systolic volume, and you can see this orange color is above, like it is increasing. So this indicates there is increase in left ventricular pressure. So left ventricular pressure is increased, end systolic volume is increased, and stroke volume is decreased. How to say that is, this black color is the imaginary normal cardiac cycle. So you can see this orange area is lesser than the black side of the area. So this represents as the stroke volume is decreased. So we need to try to identify the condition. Stroke volume is decreased, but the left ventricular pressure is increased, and the end systolic volume is also increased. So this condition is seen in actually aortic stenosis. So here the problem is the pressure, everything is fine, but the stroke volume is low because the aorta is steno, so the blood is not able to go out. So this is the problem here. So actually it is a systolic failure because now the left ventricle is not able to contract and push the blood into the systemic circulation because of aortic stenosis. So the conditions are increase in left ventricular pressure, increase in end systolic volume, no change in end diastolic volume, you can say it's normal, stroke volume is decreased. So because of this there will be of course ventricular hypertrophy because more blood is coming, because there is more left ventricular pressure greater than aortic pressure. So ventricular hypertrophy, decreased ventricular compliance, increase EDP for given EDV. So there is also another thing you can correlate with this is murmurs. Here there is a crescendo decrescendo murmur. Crescendo means first it rises, decrescendo means it decreases. Why? Because first the left ventricular pressure rises so much to open the aortic valve, but it is not able to open. But later what happened? It decreases again because the left ventricle has undergone hypertrophy now. So like that you can remember crescendo decrescendo murmur. And there is also rise in afterload. One thing you need to remember that end diastolic volume represents the preload, right? So here there is no change in preload, but there is increase in afterload because aortic stenosis, there is more resistance, mean arterial pressure is increasing. So like this you can remember. There's another variant called supravalvular aortic stenosis. This is called as Williams syndrome. It is actually a genetic deletion syndrome. Now let us try to guess this condition. So you can see here clearly that the stroke volume is increased, right? Because this orange area has crossed the black line. So stroke volume is increased, and also you can see the end diastolic volume is increased because it is normally somewhere here, but it is like about 200, 250 something like that. So end diastolic volume is increased is nothing but preload. Preload is increasing in this condition, and there is also increase in stroke volume. End systolic volume is also increase somewhat, you can see here end systolic volume also increase. So end systolic volume increase, end diastolic volume increase, stroke volume increase. What is this condition? This is actually aortic regurgitation, that is the backflow of blood into the left atrium, right? So aortic regurgitation, there is regurgitation of blood, so there is no true isovolumetric phase, increase preload, increase afterload, increase stroke volume, and there is loss of dichotic notch. So there is a blowing diastolic murmur because there is a regurgitation, backward flow into left atrium. So there is a blowing regurgitation murmur. It is having wide pulse pressure. You can see here the wide pulse pressure. That is also called water hammer pulse or head bobbing. So this is aortic regurgitation, means the blood is coming back into the left ventricle. So there is more blood in the left ventricle. So more stroke volume, more end diastolic volume, more end systolic volume, and also more preload and afterload. Now coming to this condition, if you see here, the end diastolic volume is decreased, end systolic volume is decreased, right? You can see in this graph directly. End systolic volume is decreased, end diastolic volume is decreased, stroke volume is decreased. What is this condition? It's like everything is decreased, but only the left atrium pressure is increasing. Why? Because it is a mitral stenosis. So this is a diastolic dysfunction, mitral stenosis. The mitral valve is blocked. So the left atrium pressure is increasing a lot. It is not able to give the blood into left ventricle. So in the left ventricle everything is falling, like end diastolic volume is falling, end systolic volume is falling, stroke volume is falling, preload is falling. So here you will see a diastolic rumble called as opening snap. Now coming to this condition, in this condition you can see the stroke volume is increasing, and also you can see the end systolic volume is decreasing and end diastolic volume is increasing. So So what is this condition? It is actually mitral regurgitation systolic problem. Here S3 sound is audible. Because S3 sound you can know it is seen in ventricular hypertrophy in the filling stage. So mitral regurgitation here the problem is the blood is going back, so this decrease end systolic volume, increase end diastolic volume, increase stroke volume because more blood is flowing forward flow into systemic circulation plus backflow into left atrium. End systolic volume is decreased due to decreased resistance and increased regurgitation into left atrium during systole. So that's why end systolic volume is decreased. The primary cause is mitral valve prolapse. Here there is increased preload, decrease after load, and there is a systolic click. So you can remember this by mnemonic steno snap. In stenosis you will have snap. In pro click, that is in prolapse or regurgitation you have systolic click. So this is also showing a murmur called holosystolic murmur. Now we'll wind up this topic with some other important points, like in the case of tricuspid stenosis, it is also a diastolic murmur at left lower sternal border, and also carcinoid heart disease show this tricuspid stenosis. Pulmonary stenosis is congenital and also it is associated with carcinoid heart disease. Tricuspid regurgitation also shows holosystolic murmur. So what you need to understand, any regurgitation shows a holosystolic murmur. Causes increased right ventricular enlargement, and it leads to it is seen in IV drug uses and also in carcinoid heart disease. Pulmonary regurgitation is most common cause for teratology of Fallot. Now in this JVP waves, we also need to discuss about this abnormal waves like large A wave. If you remember, this A means right atrial contraction. If there is large A wave, it is indicating tricuspid stenosis, because in tricuspid stenosis there will be more right atrial pressure, and also Canon A wave also a big A wave. It is seen in AV dissociation and in ventricular tachycardia. Sometimes this A wave is completely absent, that is in atrial fibrillation, no A wave. Giant V wave represents what? More venous filling into the right atrium. So this is giant in the case of tricuspid regurgitation because more blood is flowing back into the right atrium, so there will be giant V wave. So finally, ejection click, it is early in systole before carotid pulse. It is seen in bicuspid ionic valve, and non-ejection click is late in systole and it is seen after carotid pulse. So this is the important points. Next we'll continue with other topic. Let's continue with splitting of S2. So here first we need to try to understand this diagram. So you can see this purple color, this is representing S1, and S2 is actually split into two parts, A2 and P2. Okay, so first one is physiological splitting. Physiological splitting, before that you need to see this side, it is representing inspiration, and this side is representing expiration. So actually in physiological splitting, it is a normal delay, it is normally seen, it is not pathological. It is nothing but during inspiration what happens is there's some drop in the intrathoracic pressure. As the intrathoracic pressure is dropped, there is more venous return, so that more right ventricle is filling and there is increase in right ventricular stroke volume. So because of that, there is increase in right ventricular ejection time. So as the right ventricle, in the right ventricle there is more blood, so that there is delay in pulmonic valve, and that delay you can see as more blood is coming, pulmonic valve closes somewhat lately, and that delay is normal delay. This is called as physiological splitting. And this also occurs during inspiration, which contribute to delayed closure of pulmonic valve, and this process occurs mainly in inspiration because there is increased capacity of pulmonary circulation in inspiration. So next, coming to wide splitting. Wide splitting, in the name itself you can see this wide abnormal delay. This is also seen in inspiration, where it is seen due to delay in right ventricle emptying. So right ventricle is unable to empty, there is more blood in the right ventricle. So how to remember this? Wide splitting, persistent. Wide splitting is also called persistent splitting. Here R represents right side delay, right ventricle is unable to give blood. So examples are like pulmonic stenosis and also in right bundle branch block. This causes delayed pulmonic sound, especially in inspiration. And next, coming to fixed splitting. As a name you can see, in inspiration and expiration there is a delay. In before two examples, physiological splitting, only in inspiration there is delay. In fixed or wide in wide or persistent splitting, there is a wide delay only in inspiration, but fixed splitting you can see in both A2, P2, in inspiration and expiration there's splitting. This is heard especially in atrial septal defect because there is a shunt from left to right side. So right atria and right ventricle volumes both are increased. That will lead to increased flow through pulmonic wall. As there is more blood going to pulmonic valve, there is delayed pulmonic valve closure, and that will lead to fixed splitting. And remember, it is independent of respiration. So in inspiration and expiration there is splitting. Now coming to paradoxical splitting, it is paradoxical because it is reversed. You can see it is P2 first and A2 later, so it is reversed. So this is paradoxical splitting. Here there is loud P2 you can heard in pulmonary hypertension. Paradoxical splitting, you can remember this L as left side delay, that is here the left ventricle is unable to you know the left ventricle is pumping more blood and there is delay in aortic valve closure, so that's why it is left side. Here the examples are like aortic stenosis, left bundle branch block. So this is paradoxical splitting. P2 occurs before A2. On inspiration, P2 closes later, moves to A2, paradoxically eliminating the split. On expiration, the split can be heard, which is opposite to physiological splitting. Now coming to auscultation of heart. In auscultation of heart, the mnemonic is APTM. APTM. So let us understand about this. In this region, you can hear this is called aortic area. A for aortic area. Here you can listen to the systolic murmur, that is aortic stenosis. Systolic murmur means the heart is trying to pump the blood, but it is failing. That is called as systolic murmur. So it is seen in aortic stenosis because your heart is trying to pump but it is failing because of aortic stenosis. Next there is a flow murmur, which is a physiological murmur, and also aortic valve sclerosis. Next coming to P. P is a pulmonic area which is on the left side, left upper sternal border. Here S2 sound can be heard. If you remember S2, that is closure of both aortic and pulmonary valve, right? So it is systolic ejection murmur and pulmonic stenosis because it's pulmonary area. And atrial septal defect is also heard here, and flow murmur is heard here. Next coming to T. T is a tricuspid area, which is where you hear the holosystolic murmur. If you remember, holosystolic murmurs are seen in mainly tricuspid regurgitation, ventricular septal defect, and also here you can hear one diastolic murmur, that is tricuspid stenosis. This is tricuspid, so all are related to tricuspid. It is in the left lower sternal border. So this is left upper sternal, this is left lower sternal. Next coming to M, that is the mitral area where you can hear both all the three sounds like S1, S3, S4. Here the systolic murmur which you can hear is the aortic regurgitation and also mitral valve prolapse. Diastolic murmur is mitral stenosis. At this mitral area, all are related to mitral valve problems. So finally coming to left sternal border, here you can hear the hypertrophic cardiomyopathy, systolic murmur, and the diastolic murmur is aortic regurgitation and pulmonic regurgitation. So actually this is very important. Many questions in usmle are tested on this APTM regions, or what are the sounds, what are the conditions, so very important. Then you need to understand Carvalho's sign, that is the right side murmur which is increase in inspiration and the left side murmur is increase in exhalation. So it's time to understand different maneuvers and their cardiovascular changes. So first standing. So if you can understand, if you stand, the preload to the heart decreases, that is the left ventricular volume is decreasing. Of course preload is decrease means and diastolic volume is decrease. So in Valsalva strain phase and in standing this condition happens. So what are the conditions which increase with this maneuver are mitral valve prolapse and hypertrophic cardiomyopathy. These two conditions are increased in this manner because in these two conditions also there is decrease in left ventricular volume, because in mitral valve prolapse most of the blood is going back again into left atrium, so left ventricle volume is decreased with mid systolic click. And in hypertrophic cardiomyopathy also there is low left ventricle volume. So in this both conditions this maneuver is increased, whereas in most murmurs like decreased flow through stenotic or regurgitant valve, in these conditions this maneuver is decreased. Now coming to passive leg raise. If you passively raise your leg, your preload will increase and the left ventricular volume will increase. So most murmurs increase with this maneuver whereas these two maneuvers will decrease, because in these conditions, the left ventricle volume is increased. You can see murmurs that decrease with this maneuver, because as the left ventricle volume is increasing, there will be later mid-systolic click in this, and in hypertrophic cardiomyopathy also left ventricular volume will increase with this maneuver. Actually, there is low left ventricular volume in this both conditions, but here it is increasing because of this passive leg raise and also squatting also same condition. In squatting also preload will be increasing, afterload also will be increasing in squatting, that will lead to increased left ventricular volume. Okay, so left ventricular volume is increasing passive leg raise and squatting, and it is decreasing standing or valsalva strain phase. And in hand grip, afterload increases and there is river flow across aortic valve, so that there will be rise in left ventricular volume. This maneuver increases with left-sided murmurs like aortic regurgitation, mitral regurgitation, and also ventricular septal defect. In all these conditions, this murmurs increase with the maneuver. Whereas this murmurs decrease with the maneuver like aortic stenosis, there's decreased transaortic valve pressure gradient, and in hypertrophic cardiomyopathy, there is increase in left ventricular volume. Next, coming to inspiration. In inspiration, there will be more venous return to right heart and decreased venous return to left heart. So most of the right-sided, because right heart there is more venous return, right-sided murmurs are increased, and most left-sided murmurs are decreased with the inspiration. So next, coming to 1, 2, 3 murmurs have no thrill. That is, this 3 murmurs have no thrill, but 4, 5, and 7 murmurs show the thrill. Now coming to clues to diagnosis, very important. If there is a young female, otherwise healthy, then you can understand it is a mitral valve prolapse. If there is a young, healthy athlete with syncope, then you can diagnose it as hypertrophic cardiomyopathy. If someone is immigrant or pregnant, then you can say it's mitral stenosis. IV drug abuse lead to tricuspid regurgitation. Turner syndrome or aortic coarctation is seen when bicuspid aortic valve, early stenosis, aortic regurgitation. Marfan syndrome is associated with MVP.